Welcome to today's webinar, Strategies for Incorporating Universal Education about Healthy Relationships into Clinical Practice to Reduce Substance Use and Intimate Partner Violence. My name is Sarah King. I'll be your moderator today. I'm at NORC at the University of Chicago. Should you have any questions following this webinar or would like any technical assistance regarding SBIRT implementation, please feel free to contact us. This webinar is produced in partnership with the Brief Intervention Group, or the BIG Initiative, NORC at the University of Chicago, and the National SBIRT ATTC. Today's webinar is part of our 2016-2017 webinar series. We're anticipating some great webinars for this year's upcoming topics, and today begins our mini-series on IPV and SBIRT. You can also view any of our recorded webinars on our website. All of the materials for today's webinar, as well as previous webinars, are available on our website. We have a dedicated page specifically for today's webinar. You can find the PowerPoint slides there available for download. Any additional resources will also be posted on this page. Following today's webinar, you can access the webinar recording and any CEU information also on this page. Finally, today's webinar is approved for 1.5 continuing education hours. During the webinar, you can ask questions through the questions pane. It's located in the GoToWebinar dashboard. At the end of the webinar, we'll have a Q&A session during which we'll address any questions that have been submitted throughout the course of today's webinar. Behind the scenes today is our technical facilitator, Misty Story. If you have any technical concerns, Misty will be there to assist you. Now I'd like to introduce our presenter for today. Dr. Heather McCauley is an assistant professor at Human Development at Michigan State University and core faculty in MSU's Research Consortium on Gender-Based Violence. A Harvard-trained social epidemiologist, Dr. McCauley's NIH-funded research focuses on the health impacts of intimate partner violence and sexual assault. She has spent the last 10 years collaborating with a multidisciplinary team of researchers on brief clinical interventions to reduce intimate partner violence, sexual assault, and reproductive coercion, and school-based bystander intervention programs. It's my pleasure to welcome Dr. McCauley today, and I'm going to turn things over to her.
Good afternoon, and thank you so much for having me today. It really is an honor to be sharing this work and to learn from you to improve the assessment of intimate partner violence in the clinical setting. As Sarah mentioned, I'm a social epidemiologist, so I'm trained in public health, but I think critically about the social determinants of health, which is critically important as we think about intimate partner violence and substance use today. I've had the opportunity to spend the last 10 years partnering with the team of clinician researchers at University of Pittsburgh School of Medicine, Johns Hopkins, UC San Diego, and our community partners at Futures Without Violence, a national nonprofit in San Francisco who's really leading the charge in work on intimate partner violence. And together, we've developed clinical interventions which really teach clinicians to talk to their patients about intimate partner violence. And a key component of this work is understanding the intersections of intimate partner violence and substance use. Specifically, this work is done in collaboration with Dr. Elizabeth Miller, who's the Chief of Adolescent and Young Adult Medicine at Children's Hospital of Pittsburgh of UPMC and Futures Without Violence. Today, I'll give you a background on intimate partner violence. We'll discuss the epidemiology, the risk factors, and the health outcomes associated with violence victimization. Then we'll move on and think about the links between substance use and intimate partner violence. And finally, we'll move into our intervention strategies for talking about healthy relationships in the clinical setting. As many as 1 in 3 women and 1 in 5 teen girls will experience intimate partner violence or sexual assault. We know that young women ages 16 to 24 are at highest risk. We also know that a majority of women who have experienced sexual assault had experienced their first experience of sexual assault before age 25. So for those of you who work with adolescents and young adults, this is a particularly important issue. This is really an adolescent and young adult problem. Compared to violence against men, violence against women tends to be more severe, resulting in injuries that might need medical attention. And women are also more likely to experience sexual abuse compared to their male counterparts. However, we do know that men may experience intimate partner violence, specifically physical aggression, at the hands of a female partner. And for many years, the field was focused specifically on intimate partner violence in heterosexual relationships. And my work and the work of others has started to move us into understanding that also the experiences of lesbian, gay, bisexual, and transgender people. And we're seeing that they're at greater risk for IPV compared to heterosexual and cisgender people. The National Intimate Partner Violence and Sexual Violence Survey, which is a nationally representative survey by the CDC, conducted in 2010, found that 44% of lesbian women, 61% of bisexual women, and 35% of heterosexual women experienced IPV victimization in her lifetime. This study also found that 26% of gay men, 37% of bisexual men, and 29% of heterosexual men experienced IPV victimization. So as far as sexual orientation is concerned, you'll see that bisexual women in particular and bisexual men are more likely to experience IPV compared to their heterosexual counterparts. Evidence on transgender people has been emerging pretty rapidly, and we see that they're also more likely to experience IPV compared to their cisgender counterparts. So what are the risk factors for both perpetration and victimization? You'll see that they're quite similar. As far as perpetration is concerned, my work and my team's work is really focused on understanding gender-based power imbalances. We conducted a study among high school male athletes, both in California, and we've done this work also in global settings such as India. And we've found that men who hold more hyper-masculine, traditional attitudes about power and masculinity in relationships are more likely to abuse their dating partners compared to those who hold more gender-equitable attitudes in their relationships. We also know that adverse childhood experiences, such as witnessing violence in the home between your caregivers, experiencing child sexual abuse, having a parent who uses substances, or having a parent with a mental illness, those are risk factors for abuse perpetration. As far as victimization is concerned, we see that previous victimization, among other risk factors, is particularly salient. Adverse childhood experiences, those same experiences that I mentioned for perpetration, are important for victimization as well. Witnessing violence in the home, experiencing abuse yourself, or having a parent substance use disorder or mental illness. We also know that experiencing violence in adolescence and in young adulthood increases your risk for experiencing it later. And as I mentioned, this is really, it begins early and then it happens often. So it's important for especially those of you who work with adolescents to be thinking about IPV. Because I'm trained in public health, I spend a lot of time thinking about the health impacts of intimate partner violence and then helping clinicians make that link. And you'll see here, this is an image from the CDC, and you'll see that the health impacts are numerous. What about the mental health impacts? IPV victimization is associated with depression, anxiety, post-traumatic stress disorder, self-harm, sleep disorders, and suicidality. There are numerous physical health impacts and sexual and reproductive health impacts of IPV, including unintended pregnancy and sexually transmitted infections, including HIV. We know that it's difficult, women and men who are in abusive relationships have difficulty negotiating condom use and other forms of protection when they're having sex, which places them at risk for unintended pregnancies and STIs. We also know that IPV is associated with low birth weight and prematurity, physical injury that results in hospitalization, gastrointestinal concerns, among many, many other physical health impacts of intimate partner violence. We also know that survivors are more likely to use health care frequently over the course of their lifetimes compared to those who haven't experienced violence in their relationships. And as I mentioned, re-victimization is common and important. Abuse during childhood and adolescence increases risk for re-victimization in young adulthood. And poly-victimization is associated with poor mental health, including suicidality. My colleagues at University of New Hampshire, for example, published a study in 2012 that found that youth ages 10 to 17 with a history of polyvictimization were almost 6 times as likely to report suicidal ideation compared to their counterparts who hadn't experienced multiple forms of violence. So what about the links between substance use and IPV? There are several scenarios we could consider. Is it that IPV victimization comes first, resulting potentially in using substances as a means of coping? Or is it that substance use comes first and increases vulnerability, changes the social environment, which increases vulnerability to IPV victimization? Or is it something more complex, where IPV is associated with later substance use, and on the other hand, substance use is also later associated with later IPV? There are numerous studies I could present to you today illustrating both of those scenarios, so I'll just give you one example of each, and then I'll dive into some of my qualitative work to help illustrate some of the mechanisms that are at play here. For example, my colleague, Dr. Ann Coker at University of Kentucky, published this study in 2002. It was an analysis of the National Violence Against Women Survey, which was a one-time random digit dial survey, and they included measures such as heavy alcohol use, using alcohol at least 3 to 4 times per week and drinking at least 4 drinks per day, current drug use, recreational drug use, painkillers, etc. And we see that there were almost 7,000 women who participated in this study, and those who experienced physical intimate partner violence were more likely to report heavy alcohol use. Similarly, those who experienced coercive control and verbal abuse were more likely to report heavy alcohol use compared to those without that experience. We saw the same relationship with coercive control in all 4 of these outcomes: heavy alcohol use, recreational drug use, tranquilizer use, and painkiller use. Among men, more than 7,000 men participated in the study, and you'll see in particular recreational drug use highlighted here. Men who experienced physical intimate partner violence, coercive control, and verbal abuse were more likely than those who hadn't experienced those exposures to report recent recreational drug use. What about substance use leading to subsequent IPV? Now I'll say that much of the literature focuses on the first relationship. We look at the association between intimate partner violence and later substance use. But what about the other scenario? I published a study in 2015 in the journal Social Psychiatry and Psychiatric Epidemiology. And this was an analysis using the National Comorbidity Survey replication, a nationally representative study including more than 5,000 participants. And they used the WHO's Composite International Diagnostic Interview. And I looked at both internalizing disorders and externalizing disorders and their association with subsequent physical dating violence. Here we were able to know that these diagnoses came first before they started dating, and then I looked at the association with later physical involvement in later physical dating violence. And you'll see that this, I'll show you just some of these externalizing disorders. You'll see in particular, for example, conduct disorder. These are adjusted odds ratios. And those who were diagnosed with conduct disorder were more likely than those who didn't have that diagnosis to be involved in later physical dating violence. But I've highlighted here alcohol and drug abuse. Those who have those diagnoses in adolescence were almost 3 times or more than 3 times as likely to be involved in subsequent physical dating violence. So we certainly see an association here representing that other direction that I mentioned. We also looked at various clinical profiles of patients that we might see in our clinical setting. And group 5, which is the bar all the way to the right for both men and women, represents those who were diagnosed with a substance use disorder. And you'll see that for men, that was certainly the highest bar, so those engaging in substance use were more likely than those who had other diagnoses to be involved in subsequent physical dating violence. And for women, it was almost the highest bar compared to only disruptive behavior, that conduct disorder that I mentioned. So the implications of this study are particularly important for those of you providing care whose focus is substance use. If you're working with adolescents with substance use disorders, incorporating conversations and having conversations with youth about their relationships might be particularly important. So how does substance use impact relationships and health? What are the mechanisms that underlie these associations. Most of the studies use cross-sectional data, so we can't really pinpoint what comes first and what comes second. So substance use in these studies are considered a correlate of intimate partner violence and sexual assault. But little research is focused on how substance use and violence intersect to increase risk for poor health. So I'm going to share with you some data that are not quite yet published, but a qualitative study that I think helps us understand and start to think about the links and intersections between intimate partner violence and substance use. This is an in-depth interview study with 50 family planning clients as part of a larger randomized controlled trial. These young women were all seeking health care, and they were ages 18 to 30. Now, the interview was about their experiences of abuse. It wasn't necessarily focused on their substance use. I sat them down, we mapped out a timeline of their lives and unpacked every relationship, serious or not, in their lives, and tried to understand where they experienced intimate partner violence and sexual assault, and what were the contexts of those abusive relationships. We had one probe about whether and how substance use impacted women's relationships. And I mention that because I think it's important to understand that the goal of the interview was to elucidate women's experiences of violence, and substance use came up over and over and over again. So the mean age of the sample was 24 years old. These were young women. 28% of the participants were non-white, and 2/3 had more than a high school education. So this study was conducted in Western Pennsylvania, which really reflects the demographics of the region. And 3/4 of women felt that alcohol or drug use impacted their relationships or increased their exposure to other forms of violence. So what did that look like? First, we'll look at the links between sexual assault and substance use. We saw a consistent link in the interviews between alcohol in particular and sexual assault. This was especially relevant, and it came up the most among women who described their first sexual experience as a sexual assault. Most often, alcohol was involved in those cases. Women also had a difficult time describing what they experienced and calling it sexual assault. This was often because they blamed themselves. They experienced a lot of self-blame, especially when alcohol was involved. They'd say things like, well, I was drinking too, so it wasn't his fault. Consequently, they wouldn't discuss sexual assault with anyone when that self-blame was present, even with a healthcare provider. And often women described perpetrators using substances to control their victims. This quote is from a young woman. She was 23 years old, and she said this: I was in a situation where I liked the person, but I wasn't ready to have sex. I was pushed into it, and alcohol was involved. I was there alone. I mean, my friends had all left, and there was no getting out of it. He was friends with all of my friends. He would have said something. So I don't know. Like, it was not something that I was forced into, but it was something I didn't want to do and ended up doing anyway. Now, I bolded this last part of her statement. It was not something that I was forced into, but it was something I didn't want to do and ended up doing anyway. Because this is something that I hear time and time again in my interviews with survivors. Most often, they won't describe what they experience as sexual assault. They think it's a normal part of their sexual experiences, and consequently, they don't share this. It doesn't occur to them to share their experiences with their providers. In many cases in these interviews, myself or the other interviewers are the first people that these women have ever shared their experiences with. What about IPV specifically in substance use? Women described this normality of sexual experiences and substance use during sex. There was often described use of alcohol and other drugs to control a partner, including when and how women have sex. And women also described an escalating violence with increasing substance use. So as the relationship started to circle and focus on substance use, that's when we saw some of this physical violence in particular increase. This story was shared by a 29-year-old woman. She said this: I was 19 or 20. He was a drug addict. He wouldn't get really physical other than when we were having sex. And to me, that was okay in the relationship because that's all I knew. He would try to choke me or hit me, and he'd always be like, come on, come on. And then sometimes I would give in. It was never like he raped me or anything, but while we'd have sex, he would try to choke me and be physical like that, and he convinced me that I liked it. So again, you'll hear that phrase, it was never like he raped me. This is language that I hear in many interviews with young women. And you'll see here this normality that women think that physically violent sex in this case, even if it's not something she wants, is just a normal part of her relationship. This 27-year-old woman shared this. At the beginning, we drank just to have a good time. Then as our relationship progressed, it was drinking so I could continue onwards without thinking about what was going on. There were times he'd have me drink more than I'd want to, more than I'd like to, just so we could have sex, or so we could have sex his way, or whatever he wanted to do. He basically knew if you could get me to drink more than I wanted to, or more than I'd like to, then he was in complete control, and he could control who, what, where, when, how, everything else that was going on. So here you'll see that alcohol, in the context of this abusive relationship, makes it difficult for women to share how they want to have sex and negotiate condom use, for example, and that it really inhibits that communication. This 20-year-old woman shared this. I get drunk or high about half the time we have sex because it gives me this numb, okay feeling, kind of like flying and making somebody happy at the same time. I'm not as closed up, not as scared. It's hard to explain the feeling. It makes me feel a lot more comfortable doing stuff like that. And so you're starting to see with these quotes the links and the intersections of violence and substance use and sexuality. Women also described numerous experiences of unwanted sexual behavior, which I've already given you examples of, and then also sexual risk-taking behavior, including sex trade. A 24-year-old woman shared this. I was raped. I was 17. This man, I was with my friend and we were going to buy drugs, and he ended up taking advantage. That changed how I felt about sex, because from that point on, I was very careless sexually. Multiple sex partners, no protection, no birth control. For the longest time, I would trade sex for money or for drugs or for clothes or for, a lot of them were people I knew. I did escort for a little bit, and that was arranged. I needed to pay my bills, and I needed to eat and have money, and that's all I could think of to get money. So you'll remember I said at the beginning of this section that this study was not necessarily to understand the intersections of substance use and violence. It was really to understand and really just have a better understanding of the context of their abusive relationships. And substance use emerged, oftentimes organically, as a really critical component of that context. So it's common among this sample of women seeking care in the sexual and reproductive health setting, and it amplifies violence in their relationships. And the intersection of violence and substance use impacts women's risk for poor sexual and reproductive health. Women described limited ability to negotiate condom use and when or how women have sex, especially if they've experienced violence before. And when substance use is present, women might be afraid to negotiate condom use or how they want to have sex, or they might be exhausted by doing this over and over again in their relationships. And so that really inhibits and impacts their risk for STIs and unintended pregnancy. Also, sexual behavior under the influence is perceived as normal. So this is more of a young adult sample, a little bit older than some of my other populations that I work with, but sexual behavior and alcohol use and drug use is perceived as a normal part of their relationships. So what do we do about this? How do we think about violence and substance use in clinical settings? My colleague Judy Chang at University of Pittsburgh has done a lot of work with survivors to understand just this question. And survivors say that they want providers to be non-judgmental, to listen, to offer information and support, and to not push for disclosure. And so this last piece, I think, is the most challenging for many clinicians I work with. So first I'll say this, why is disclosure not the goal? Survivors have many reasons they may not disclose experiences of trauma to their provider. They might fear the consequences. What's going to happen if I share this experience with my provider? Especially if children are involved. They might worry about, for example, the involvement of Child Protective Services. They might not trust systems, especially for those who have experienced trauma before and have had experiences interacting with systems. In many cases, these systems have not identified and picked up and helped these survivors, so they might not trust these systems. There might be a desire for violence to end, but not the relationship. And I think this is also a piece that clinicians struggle with, especially for those who are trained to come up with a diagnosis and solve the problem. But leaving an abusive relationship can be challenging and complicated at best and can be lethal at worst. It's especially dangerous when survivors are leaving an abusive relationship. And in many cases, survivors have been with their partners, they might have children, they might be financially tied to the person. There are a lot of complications that make this leaving difficult. They also might be worried about potential loss of support. And I think about this in particular with my LGBT participants that I work with. For those who are experiencing, for lesbian, gay, bisexual, and transgender people who are experiencing violence in their relationships with LGBT partners, they might be worried if they disclose abuse they've experienced that they are betraying their community. And so they might be worried that they're going to be first discriminated against when they share what they've experienced, but then lose the support of their community. What about the flip side? What are struggles that clinicians have with having this conversation? Providers have identified the following barriers. Some might say it's outside their scope of work. So whatever their role is in the clinic or whatever their specialty is, they might not think that assessing for violence and thinking about violence is an important part of their practice. And here my goal today is to really help make the links, connect the dots between violence and health, so that that barrier becomes a little bit less of a problem for people. Some might have discomfort initiating conversations. These can be hard conversations, especially for providers who've experienced violence themselves. This can be particularly challenging. They might not know what to do about disclosures. They might say, I feel comfortable asking the question, but I wouldn't know what to do if they said yes. So some of our work has been connecting clinicians to violence resources in the community, helping to make that link, bring advocates into the clinical setting so that they know each other on a first-name basis. I don't expect my clinicians to be experts in violence, but I do expect them to know who is in their community, and we'll talk about that a little bit later in the presentation. They might worry about mandatory reporting, and I understand that fear. That's something that we address, discuss limits of confidentiality at the beginning of every interaction with a patient, especially while disclosure is not the goal of these conversations. Disclosures might happen, and mandatory reporting might have to occur. So thinking about that is certainly an important part of any intervention training that we do. Clinicians might feel frustrated with patients who did not follow a plan of care, especially if the approach and the idea is that we want them to leave the abusive relationship. They might be frustrated when that doesn't happen. So here, if we shift away from worrying about that disclosure and worrying about helping someone leave an abusive relationship and really circling back and thinking about how we can provide the best health care we can for our patients, that can hopefully ease some of that frustration. And then also there's the very real barrier of lack of time in clinical settings. Often we only have 15 or 20 minutes with a patient. So thinking about that, our approach that I'm going to be talking about today is intended to fold right into what you do already, to limit this additional additional time that you would have to add on to your visits. That said, certainly if someone says yes, they've experienced violence, then that might lead to a longer conversation. So this approach, providing universal education on healthy relationships. I talk to all of my patients about healthy relationships. And we're shifting the approach from some of the traditional ways that we've asked patients about violence. For many years, the question was, have you ever been hit, kicked, slapped, or choked by a current or former partner? Not only is that a mouthful to say, it's probably not something that someone is going to say yes to. Other questions that we hear, no one's hurting you at home, right? So with that tone, the partner, first of all, this question might be asked with a partner seated next to a client, which is dangerous. And then consider how the patient feels in this situation. That tone, no one is hurting you at home, right? Sends the message that you're hoping they're not going to say yes. Or, within the last year, has he ever hurt you or hit you? And that's a little better, but this is often asked with providers back to the patient while typing on a computer screen. So think about the message that that body language sends to the patient. Another question that I hear, I'm really sorry I have to ask you these questions. It's a requirement of the clinic. So what is the staff communicating to the patient if you apologize for asking about their relationship? So we're trying to shift away from some of those approaches. This intervention is called GIFTS, Giving Information for Trauma, Support, and Safety. First, you start discussing the limits of confidentiality, and I'll go much more into detail about these steps moving forward, but I want to give you a quick overview. So you'll discuss the limits of confidentiality, you'll provide universal education on consensual sex, healthy relationships, the links between violence and substance use, and harm reduction to every patient that comes into your clinic. And then you can conduct a direct assessment for violence. If it's disclosed, you talk about harm reduction strategies that are related to the reason why they're coming into the clinic. And I'll give you examples of that later. Also, if violence is disclosed, talking about warm referrals to advocacy services. Because at this point, we've made the connection between you and the domestic violence advocates in the community, you can say to someone, hey, I know so-and-so at this advocacy organization, and they're really great. Let's make that call together. Or would you like us to invite that advocate to the clinic? We can do that together. If violence is not disclosed, you still provide information on resources in case they have experienced violence and they're just not telling you about it, or they haven't experienced violence, they can share that information with their friends. So how is this approach different from traditional IPV screening? There's a focus on prevention in addition to intervention because we're providing universal education on violence and healthy relationships for every person walking into the clinic. All patients have access to information, not just those who disclose, because disclosure is not the goal. And violence advocates are key members of the healthcare team through those warm referrals. So I'm a public health nerd, so we'll talk about this in terms of primary prevention and secondary prevention. So for primary prevention, for clients not experiencing abuse, universal education affirms that violence is an important healthcare issue and provides an opportunity to learn about healthy relationships and what constitutes abusive behaviors. What about secondary prevention? In the early stages of an abusive relationship, early identification and intervention can prevent serious injuries and chronic illnesses as the violence escalates and the entrapment increases. And here, I also think it's important that in many cases, and I work with teens most often, and in many cases, they don't describe what they're experiencing as abuse. They don't recognize that as abuse. They think it's part of their what a normal relationship should look like. And so I think having these conversations is critically important for those who are experiencing it. They're at this place. They're in those early stages to help them make the links and understand that what they're experiencing is not normal. And then tertiary. In relationships with escalating violence, direct assessment provides the opportunity for disclosure in a safe and confidential environment, even if clients don't feel that safe disclosing, if they don't feel safe disclosing their abuse, giving these supportive messages can end their isolation and let them know that they have options. So I'll go through several key resources that have been developed to facilitate these conversations. This work has been done in partnership with Futures Without Violence, and these materials are all produced freely, and they're freely available for you to order and facilitate these conversations. The materials include a palm-sized safety card, so it's about the size of a business card, and it unfolds, and I'll show you what the panels look like in a minute. And they also several of these cards come with accompanying clinical guidelines, which actually walk you through panel by panel and give you specific scripts for having these conversations. So this is the adolescent card. It's currently under revision, I believe, because I've seen the new images for the front of the new card, but it's generally, it will generally be the material that I'm sharing with you today, and the conversation will certainly be the same. So these These intervention materials and these safety cards are a simple evidence-based intervention, and I'll share with you some of our evaluation results a little bit later. It's an opportunity to talk about healthy relationships, provides that primary prevention that I mentioned by identifying signs of an unhealthy relationship, and you educate clients about what they can do if they have a friend or family member who might be struggling with abuse. You plant seeds for adolescents who are experiencing abuse but not yet ready to disclose, and you help those victims learn about safety planning, harm reduction strategies, and support services. So clinicians do this a little bit differently depending on how they feel comfortable interacting with their patients. Some clinicians use this card and go through panel by panel with their patients. Some use it to start the conversation, and then they hand the card to the patient and leave the patient to read the material. But either way, you start by normalizing this conversation so that patients begin to expect that you're going to ask them about relationships. So we started to talk to all of the young people in our clinic about what they deserve in relationships. And then you unfold the card, and you say something like, see, it's kind of like a magazine quiz, and it talks about the difference between healthy and unhealthy relationships and tells you how to get help or help a friend if anything like this is happening to them. So the safety card covers a range of issues. This is an example of one of the panels. And you start with healthy relationships. How's it going? Does the person you're seeing treat you well, respect you, giving you space to hang out with your friends, let you wear what you want to wear? If you answered yes, it sounds like they care about you. So you're starting from this place of a healthy relationship before jumping into some of the signs of an unhealthy or abusive relationship. The second panel, for example, not on a bad day. How often does the person you're seeing shame you or make you feel stupid, pressure you to go to the next step when you're not ready, control where you go or make you feel afraid, grab your arm, yell at you, push you when they're angry or frustrated? Nobody deserves to be treated this way. If these things ever happen in your relationship, talk to someone about it. You can, at a side note, you can say this is when you can kind of insert, you can talk to me about it. This is a place you can come to talk to about what you're experiencing. And then it provides the loveisrespect.org, a fantastic resource for young people. So you'll see here that we tried to address both some of the physical violence that they might be experiencing and then some of the more verbal or emotional control that they might be experiencing in their relationships. And what about respect? Anyone you're with, whether talking, hanging out, or hooking up, should make you feel safe and comfortable, not pressure you or try to get you drunk or high because they want to have sex with you, respect your boundaries, and ask if it's okay to touch or kiss you. So here we're talking about and helping them recognize what is a healthy relationship, what's not a healthy relationship. And then you'll see here this language, how would you want your best friend, sister, or brother to be treated by someone they were going out with? Ask yourself if the person you're seeing treats you with respect and if you treat them with respect. And here, this language, for those who don't want to admit that this is what they're experiencing, kind of framing it in terms of, well, if you see this happening in your friend's relationship, then you can do something about it. Help survivors who are experiencing it themselves feel powerful in that situation, to be able to share this knowledge with others. We're also seeing in our work that cyber dating abuse is incredibly common and associated with physical and sexual violence in their relationships and poor health. And with social media, I don't think anyone is surprised that this is happening with the ubiquitous nature of social media in our young people's lives. So we wanted to address that here with a panel about texting. So getting a lot of text can feel good. Wow, this person really likes me. What happens when the texts start making me feel uncomfortable, nervous, or they keep coming nonstop? Or figuring out what to say can be hard, especially if you like the person. Be honest, I really like you, but I really don't like it when you text me about where I am all the time, or pressure me for naked pics. And then it provides another fantastic resource, www.that'snotcool.com, which is a resource for teens that talks about cyber dating abuse. And here, how to help a friend. In this panel, we've done interviews with survivors who've experienced all forms of the intervention. So here in the adolescent setting, in the reproductive health clinic setting, and we're finding that survivors feel empowered with the ability to help others. So that's what this is about here. So do you have a friend who you think is in an unhealthy relationship? And then it gives them steps to help them. So again, each provider does it differently. And I'll share a quote at the end from a young woman who experienced the intervention. Some providers actually sit down with the patient, especially the adolescent patients, and go through panel by panel and start the conversation. And others just use it as a prompt to have a broader conversation about their relationships. We're also currently evaluating, and all of this work is led by Dr. Elizabeth Miller, these intervention studies. And this one is currently, we're evaluating this college card in approximately 30 college health centers in Western Pennsylvania. So this is developed, you'll see the adolescent card with focus more on healthy relationships. Here's where we start to escalate some of the material and talk about the links between alcohol and sexual assault. With this card, as with all of the cards in this series, there's an opportunity for education and that anticipatory guidance. So you start with this. So at some point you might be asked, do you want to hook up? But the reality is you might not have that choice. And then there's statistics here on college sexual assault, including, in fact, 1 in 4 women will be sexually assaulted in college, and 70,000 students per year are victims of alcohol-related sexual assault. Sex when you can't give consent is criminal and not consensual. This can happen with someone you know, and even with someone you've slept with before. This card has information for you and your friends. And so this might be the first time that students have had the opportunity to talk about sexual and intimate partner violence on campus. The college card also does some myth busting about the links between alcohol and consent, because you'll hear people say that alcohol causes sexual assault, and we're finding in the literature that that's really not the case. So here, I think this panel is particularly important for our college students. So it defines consent, a voluntary active agreement with any person you do something sexual with or have something sexual done to you. Here's the deal. We live in a world where women often get blamed or judged for being sexually assaulted. Sometimes women think because they were wasted, what happened was their fault. You can't give consent if you're drunk or high, asleep, or too afraid to say no. If you can't give consent and someone has sex with you, it's a crime. So this panel serves as a conversation starter about consent, the role of alcohol in young people's sexual lives, and reducing that victim blaming that is so common. The one potential difference with this card and some of the other cards is here we also have an opportunity to empower young people, and I want to say that this card is both for men and women, to really step in and say something if they see this happening in their social circles. So there's a big push in the sexual assault prevention world focused on bystander intervention, so teaching people to step in. And this card also facilitates that conversation, which is a potentially new addition to the clinic, but it makes a lot of sense in the context of this work. So you've probably heard a lot about the role fellow students can play in helping prevent sexual violence. This card offers some more information. So it encourages helping friends, and it's still this universal education, this universal intervention that everyone walking into the clinic gets this message. It's also important to connect to health. So patients might not know that violence can have an impact on their health. So it wouldn't occur to them to tell you that that's what they've experienced. When you make the connection for them, the conversation doesn't seem out of left field. So for example, because sexual violence is so common and has so many health repercussions, we like to talk to all patients who come in for whatever visit type about relationship violence or sexual violence and experiences they might have had. I worry about people making you do things sexual that you didn't want to do. This is often the language that clinicians feel comfortable using. I worry about, did anyone make you do something sexual that you didn't want to do? And we provide a couple visit-specific scripts, and I think we could work together to come up with many, many more. But here, for example, if they're coming in for an STI test, anytime patients come in for STI or HIV testing, we always ask if they feel comfortable talking with their sexual partners about condom use. Or for birth control, do you feel safe asking your sexual partners to use protection? For example, an STI diagnosis. Some of our patients share with us that telling a partner about an infection so that they can be treated can be pretty scary. How is the person you're having sex with going to react if they find out about this infection? And what about substance use? We can discuss the interaction of substance use, sexual activity, and relationship safety in the context of the same conversation. So you could use something similar to what I've used in my qualitative studies. How have drugs or alcohol been a part of your relationships? Has what's going on made people you've had sex with make you feel like drinking or using more? So helping to understand and unpack potential coping mechanisms. Or has anyone pressured you to drink or use drugs? I'll mention in a minute what to do if someone says yes, that this is what they've experienced, but I just want to share with you this image of the safety card that includes safety planning and harm reduction. So if someone says, yes, I'm experiencing this, you can do some safety planning and harm reduction that's really relevant to the reason why they're seeking care. So here, for this college card, when sexual assault happens, there are things that you should know. You can take emergency contraception. Often it's helpful to talk to a sexual assault advocate, a trusted adult or friend. If your school has a student health center, they can help. Or sexual assault advocates will help you, whether you want to pursue legal action or not. So again, you'll see that we really include domestic and sexual violence advocates as key components of this intervention. For the college card, there's also a nod to technology because there are certainly apps emerging daily. And this particular one is pretty great. Circle of Six is a safety app where you can program in the contact info of 6 friends. And so if you're in a situation where you feel like you need some help, you push a button and a message goes out to all 6 of those friends. And so here, but I do want to emphasize that technology can play a role in safety and harm reduction, but it's important to remember that these tools are not intended to shift that responsibility to survivors. It's really avoiding victim blaming here. It's just one potential tool to add to their toolbox. So what do you do if someone says, yeah, I'm going through this? That sounds like my relationship. First, you want to thank the patient for sharing. You want to convey empathy for the patient who's experienced fear, anxiety, and shame. It takes a lot to say, yeah, this is what I've experienced. You want to validate that violence is a health issue that you can help with. Again, so often they haven't made that connection to violence and health, so it might not occur to them to share with you that this is what they've experienced. So you want to make your clinic a place that they know they can come to. You want to let them know that you'll support them unconditionally without judgment. You can discuss where a patient can go to learn more about and obtain birth control, et cetera, if that's not your clinic. You can ask a patient if they have immediate safety concerns and discuss options. You can refer to a violence advocate for safety planning and additional support. And then you'll schedule a follow-up visit. So what about harm reduction in this context? This really came out of the substance use field, and we're starting to incorporate it more and more into the intimate partner violence and sexual assault fields. You can have a patient use a phone in the health center to make a confidential call. So whether that's to a violence advocate, as I mentioned, that's one strategy, or to have whoever they need to make that call to. Making those resources available in the clinic can be incredibly helpful. You can also talk about safer partner notification for sexually transmitted infections, because it can be pretty dangerous if you're in an abusive relationship to tell them that you've experienced an STI or you've been diagnosed with an STI. So in some cases, depending on where you live, the health department often has anonymous partner notification strategies, or the clinician can actually invite the partner into the clinic to have that conversation. You can also discuss an IUD, so an intrauterine device or implant, for patients who are experiencing reproductive coercion. Reproductive coercion is a form of intimate partner violence or coercive control where a partner will interfere with a woman's reproduction to promote a pregnancy. That might look like partners flushing birth control pills down the toilet, or poking holes in the condom, or taking the condom off while having sex on purpose to promote a pregnancy. So for those who are experiencing reproductive coercion, moving them to a form of birth control that they can control themselves instead of having a partner be able to interfere with that can really improve and impact their sexual and reproductive health. You can talk about a buddy system or a designated driver at a party. So does a brief harm reduction intervention work in the context of intimate partner violence and sexual assault? As I mentioned, we've done interviews with survivors who have experienced the intervention to really understand and improve some of these conversations. A 24-year-old African-American woman who finished college who experienced the intervention, she shared this with us. The provider would just open the card and ask me if I had ever seen it before. And the first time I hadn't, and she sat with me and went over everything. It was awesome. The provider said, no matter what the situation you're in, there's something or someplace that can help you. I don't have to be alone in it, because that was really huge for me. I was alone most of the time for the worst part. I was just by myself. I didn't do anything. So just letting me know that there's all types of things that I can do anonymously, that was big for me. And these are evidence-based interventions. Our reproductive coercion intervention, and that card is shown down here on the left. The card titled, Did You Know Your Relationship Affects Your Health? And we tested the reproductive coercion intervention in family planning clinics in Northern California, and we just wrapped up a large randomized controlled trial in 24 family planning clinics in Western Pennsylvania. And across these studies, we've seen decreased pregnancy coercion, increased independence from abusive relationships, even though, again, that was not necessarily the goal in the first place, but that is something that we are seeing in our patients, and increased self-efficacy to use these harm reduction behaviors. Our adolescent relationship abuse intervention, which I talked about, and the card is shown down here on the right, we tested that, and that was funded by NIJ, and we tested that in school-based health centers with adolescent patients 14 to 19. And there we saw a decreased incidence of relationship violence, which was incredibly exciting. Both interventions, we saw increased knowledge of local violence resources. Clients indicated a high likelihood of sharing with friends or family. In many cases, the patients could tell us where they kept the card, who they gave it to. And clients appreciated the opportunity to discuss relationship safety with providers. There are numerous exciting next steps. My work is starting to really move and focus on understanding why LGBT populations are more likely to experience violence in their relationships. And so Futures About Violence led the development of cards that were specifically for lesbian, gay, and bisexual and transgender people. The card for lesbian, gay, and bisexual people is shown here on the left, and the card for transgender and gender nonconforming people is shown here on the right. And here was an opportunity to think about and pay attention to the unique vulnerabilities of LGBT people. Substance use disparities are one of those unique vulnerabilities. And so there's particular language in these cards that addresses that. So I'm excited to lead the evaluation of a large randomized controlled trial. We're currently recruiting clinics to be a part of this study. I really think, and what we've seen is that every clinical encounter is an opportunity to convey prevention education messages about healthy relationships, share with youth that your clinical space is safe and confidential, and identify and support those who may be experiencing controlling and abusive behaviors in their relationships. For those of you, and I know not all of you on the line are clinicians, for those of you who are advocates, for those of you who perhaps are social service professionals, I'm working with a team here to start to think about how you can think about violence and fostering those connections with healthcare services in your communities. For example, I have a study working with young women in foster care, and we're seeing that they're experiencing tremendous amounts, or they have experienced in their lifetime, tremendous amounts of intimate partner violence, sexual assault, and reproductive coercion. So how do we work with social service providers to connect young women to needed healthcare services to have these conversations? Also incorporating conversations about sexuality, substance use, and those intersections into routine practice is an important next step. I provide several resources here. The National Health Resource Center on Domestic Violence, which is on the Futures About Violence website, where you can access and order all of the materials. You'll see that we have intervention cards. We have numerous intervention cards available. And then there's a website for adolescents here that I mentioned about cyber dating abuse. That's notcool.com. Thank you so much for your attention today, and I really look forward to engaging with you about this important issue.
Thank you, Dr. McCauley. That was a great presentation. We do have a ton of questions that have come in so far, so I'm just going to start at the very beginning here. So this first question is in regards to your study itself. So you talked a lot about the work that you've done working with victims of IPV, but have you done any work with perpetrators of violence?
So work with perpetrators has not been in the clinical setting. Our work with perpetrators has been in, so far, the context of schools and communities. For example, our team evaluated also a Futures Without Violence sponsored program, Coaching Boys into Men, which was a bystander intervention program where coaches delivered messages about healthy masculinity and relationships to their male athletes. And we did find, we tested that in 16 high schools in Northern California, and we did see that boys who participated in the program were less likely to abuse their dating partners at follow-up. So that's an important program that we've evaluated, and it's starting to really disseminate and cross the country, which is pretty exciting. But we haven't done this in clinical settings quite yet. We're also working, Dr. Miller in Pittsburgh is doing an evaluation, CDC-funded evaluation right now, of a sexuality and violence intervention curriculum with boys in communities. And it's being implemented and delivered on weekends with collaborations, including the Urban Center, the Urban League of Greater Pittsburgh, YMCAs, et cetera. So moving into the community settings to have these conversations with young people was also an important goal of the team.
Great, thank you. This next question is in regards to your clinical profiles bar graph from very early on in the presentation. So the question is, it references that there's no psychiatric diagnosis, but does this also include personality diagnosis as well?
Let's see here. We'd have to go back to the slide for me to take a look. Let me see if I can pull it up quickly in front of me.
Sure, thank you.
Yeah, so group 1, the no psychiatric disorder, that was no psychiatric disorder at all. Group 2 included internalizing disorders. Group 3 then moved into ADHD. Group 4 moved into conduct disorder, disruptive behavior, and then Group 5 was substance use disorder. So no personality disorders were included in Group 1.
Okay, thanks for clarifying. Our next question is, how exactly does disclosure betray the LGBTQ community, and in what sense do LGBTQ persons feel they're betraying the community?
Yeah, that's a great question. Thank you so much for asking. So the work is starting to emerge now. We're seeing in these big epidemiological studies that LGBT people are more likely to experience violence in their relationships. But what I will say is that in many cases, these studies don't identify in what kinds of relationships they're actually experiencing abuse. So first, I'll say that I found that association in actually this family planning setting. I found that women who had had sex with women in their lives were 3 times more likely to experience intimate partner violence. But what I couldn't tell you is whether they experienced violence in their relationships with men or women. So I actually got funded by the NIH to go back and do more qualitative interviews with them to unpack and figure out what was going on in their relationships. And in their relationships, they were primarily experiencing physical and sexual violence in their relationships with men, and then some emotional abuse in their relationships with women. Not exclusively, but that was the general trend that we saw. So first I want to remind everyone that just because someone identifies as lesbian, gay, bisexual, or transgender, it doesn't tell us much about who they're actually in relationships with, their sexual behavior, and so I do want to point that out first. So sometimes we see with LGBT survivors, especially if they're experiencing violence, so for example, a lesbian woman who's experiencing violence in a relationship with a woman, a lesbian woman, she might, because of the stigma and discrimination already experienced by the community, they might not want to say that this is what they've experienced because they're afraid that that's going to bring more stigma and discrimination to the community. They're afraid that people are going to say, wow, LGBT people are really violent in their relationships. And so someone might, which is not necessarily the case, especially because we know, because of my findings, that identity and behavior aren't overlapping the way we'd think necessarily, so we don't know who they're experiencing violence with. So many survivors are worried about that. It's also particularly salient for bisexual survivors because they live in this place where they're experiencing discrimination from heterosexual people because they're bisexual, and they're experiencing stigma and discrimination also within LGBT communities in some cases. There's a lot of stigma, and that's why we see bisexual people are more likely to experience a number of health outcomes compared to both gay and lesbian and their straight counterparts. And so I think I see, when I talk to survivors, I see that fear in particular for bisexual survivors.
Okay, thank you. The next question is, if both male and female parties are intoxicated and they have sex, is the male responsible for sexual assault, or have they committed a crime if both parties are intoxicated?
Oh, that is such a challenge. That's the question that everyone is asking themselves right now. I think that if someone is intoxicated and they cannot consent, then if someone has sex with them, then that is sexual assault. But I think this brings up a larger question about consent and where that line is with alcohol and sexual assault. And I'll say that I'm not necessarily an alcohol sexual assault. That's not the focus of most of my work, but I think my colleagues who do a lot of sexuality work are really hoping to have these conversations as part of prevention programming in college students' health settings. I don't have a better answer because that's a really tricky one that we're struggling with right now.
And actually, I can follow up on that, Dr. McCauley. I do prevention work, and this is a question that college students ask in prevention seminars. And usually what we explain is that the best way to address the situation as someone immediately involved in the situation is to work on creating a sober situation before making any decisions about sexual conduct that you want to participate in. But it definitely comes up from the student perspective in a prevention presentation as well.
Yeah, absolutely. And helping young people understand that having sex sober is not abnormal. So I think people, because of this normalization of alcohol use in particular and sex, I think we need to work on shifting some of those norms. And more for, not even just for adolescents, but for all of us.
Absolutely. Okay, our next question here is, do you have any suggestions on how someone could help a patient who's experiencing long-term IPV, where they use cocaine to help with stress and they live with a perpetrator or do not want to go to a shelter? So implicating substance use issues and then also access to resources.
So did you say at the last part of that question that they don't want to go to a shelter?
Correct.
So you could certainly have the conversation to see if they want an advocate to come into the clinical setting and at least have conversations together. I think that's one strategy. And these conversations have to be really survivor-driven, which again, it can be frustrating sometimes for clinicians who want to help and the survivor's not in that place where they are interested in moving forward with anything. And so if you create a place where they know that they can talk to you about the violence that they're experiencing, I think that's an important step. Talking about harm reduction and thinking about how this particular survivor scenario is impacting her health. Those are some of the strategies that you can that you can talk through with her.
Okay. How would our participants be able to obtain copies of the cards, the resource cards that you shared today?
Yeah, so they're all available on Futures Without Violence's website. So it's futureswithoutviolence.org. And I believe if you click directly on the link or put the link that I have in that last panel into your web browser, you should go to the National the Resource Center, and you can both download the materials and you can order hard copies. They're freely available, produced through donor and grant funding, and those can be shipped directly to you. And again, there are also clinical guidelines which go along with some of the cards, which are fantastic because they give you potential scripts. And I know that every provider has a different style for having a conversation with their patients, but some of the scripts can be useful.
One of our participants is hosting a sexual health and IPV workshop with 9 to 14-year-olds, and they feel like it would be great to be able to share these cards with them. but do you feel that the cards would be beneficial to give to young men as well?
Yeah, absolutely. And actually, the adolescent card was really designed to be for both young men and young women. I certainly think that and both young men and young women were included in our study. So yeah, definitely young men as well. And actually, the college card is also for both men and women. I think the only one that I've been a part of evaluating that's focused specifically on women was the reproductive coercion card, and that was focused specifically on women. And then our LGBT cards that are coming out, they've already been released, but I'm going to be moving forward and recruiting clinics to evaluate the materials. Those cards are both for men and women and for transgender and cisgender populations.
Okay, great. Why is IPV greater for bisexual men and women compared with heterosexual or same-sex relationships?
So I think it goes back to what I was saying before about the unique vulnerabilities of bisexual people. So they experience a lot of biphobia and discrimination from both gay and straight communities. There's a lot of misconceptions about what bisexuality is, and I think that creates a scenario where they feel excluded from both communities and really increasing their vulnerability to violence in their relationships. Especially in one coercive tactic that can be used in those scenarios is that an abusive partner can threaten to out a person, for example, which helps or which facilitates and makes it hard to disclose that this is what you're experiencing to others. So there's a lot about biphobia, homophobia, and transphobia, but in particular for bisexual people, I think that contributes to some of the health disparities that we see.
Okay. Can you talk about how ADHD plays a role in IPV? I know you addressed it, but could you maybe refresh for the participants and expand on it a little bit?
Yeah, unfortunately I can't. I'm not an expert in ADHD. Let's see if I can reference you to. There's a team at Pittsburgh. The Pittsburgh Girls Study I know has done some work on ADHD. Mike Marshall, a team at University of Pittsburgh Department of Psychiatry has worked more on ADHD than I have. So unfortunately, I can't speak to that today.
Okay, that's no problem. I just want to remind our participants you can continue to submit questions to the questions box. Moving on to our next one. When a woman tolerates various types of sexual violence but remains in the relationship, how is the male to know that that behavior is not acceptable and that it might ultimately lead to criminal charges against the male? And that those charges could result in serious consequences for the male who perhaps does not see their aggressive sexual acts as undesirable.
So I can't necessarily speak to the legal aspects of this because my training is not in the law, and that hasn't really been a part of our work. But I can say I think that's why working with young men and engaging men is such an important part of this work. And I can't say it's brand new to the field, but it certainly has been something, kind of a shift that happened in the field over the past 10 or 15 years where we recognize that we have to include men's voices in these conversations. And some of this work, for example, with coaching boys into men and having conversations about masculinity and healthy sexual relationships and healthy sexuality has been a critical part of that. That's why Dr. Miller's work in the community with young people is really critically important. She's having conversations in the community with young people about questions and topics that they're not getting in other parts of their lives. And so I think that taking a step back from your question is really starting this prevention work and giving men an opportunity to be involved in this work, but also before that, having conversations with them about what healthy sexuality looks like.
Great. Okay. Why are people repeatedly victimized with IPV? It would seem that they would become more cautious after experiencing IPV, but obviously the statistics show that re-victimization occurs quite often.
Yeah, and I don't think explicit concrete mechanisms have really been elucidated well in the literature, but I will say that I think experiencing victimization, in some cases it makes you more cautious, but I think also It also changes, it increases, it might, so for example, if you've experienced violence before, you might have a difficult time having conversations, for example, in the context of your sexual relationship, having a difficult time negotiating condom use. You're worried about negative reactions if you have those conversations, so fear is also certainly a part of that. And that's the part that I talk with women about most often. I'm sure there's other mechanisms, but that's the piece that I've spent the most time thinking about.
Okay, again, I just want to remind our participants, feel free to keep submitting questions. We're happy to take more as we have a little bit more time here. The next question is, would you recommend the cards be presented in a workshop for adult substance users that are in recovery?
Yeah, absolutely. You know, so probably not the adolescent card, and maybe not. And there are certainly there are more cards than just the cards that I've shared with you, so I welcome you to take a look at that website, because I think there have been cards that have focused specifically on HIV. There are cards that have been developed for home visitation, so there are certainly lots of other forms of these conversations that all use the same intervention approach. So I would peruse those options. And I do think even the reproductive coercion card might be particularly salient for those in recovery. I worked with a team at Northeastern and in Boston, working in a substance use treatment program, and we were evaluating an HIV prevention program that was folded into that program. And trauma was a common story of the women that were participating in our study, and so we provided them an opportunity to bring it up, and they had never really made the links between trauma and their substance use. And so I do think that there's absolutely a place to have a reason and a way to have that conversation with those in recovery. I think that's really important.
Okay. Heather, do you have any closing thoughts or anything you'd like to share about the work you're doing in the future, or the work that Dr. Miller is doing?
Yeah, I guess I would like to say, for those of you who are focused and your expertise is in addiction, I would love feedback on strategies and conversation starters that you've used in your practice that you think would align well with this intervention work, especially because we're just launching it with the LGBT work, which is focused really on intersections of violence and substance use. I would love your feedback there, or if you're interested in getting involved, definitely reach out. I really thank you for your feedback, and I look forward to engaging with you further on this topic.
Great. We just have one last question come in here. Do you have any suggestions on safety or planning for how to get out of a domestic violence home, such as having a go bag or any other suggestions?
Yeah, certainly. And I think that while I didn't talk necessarily about some of the traditional safety planning techniques that have been used in the past, that it should be part of the conversation as far as harm reduction. Yeah, we often say survivors have a bag ready to go, or have important papers together in case you have to leave quickly, including money or passports, etc. If you have weapons in the homes, and knowing where those are, and thinking about talking with someone about those and how those increase your risk for violence. So thinking about what to do about knives, for example, or firearms. And medications. I know that with some of the LGBT patients that I've worked with, for example, medications for among my trans patients, having access to those, and because perpetrators can use those as a means of coercion by restricting access to those. So thinking about getting those together in a place, and talking with your provider about ways to have access to those if you need it in an emergency situation. I also want to just close with saying that, again, providers can help make the link to domestic and sexual violence advocates, who are really the experts in doing that work. So you can invite those advocates into your setting, whether that's a clinical setting or another social service organization. Forming those relationships can really be beneficial when the time comes that you need to make that call. So I don't expect necessarily clinicians to be the experts in domestic and sexual violence, but I'm hoping that they know who to reach out to. And you can, in an emergency situation, it's not uncommon to call an advocate, and they're very happy to come to your space and have conversations with your patients to make sure that they're safe.
That's great. Thank you so much, Dr. McCauley. This has been a great discussion, a great presentation. Could you share the website where the cards are accessible one more time for participants?
Sure. Let's see. Let me pull up my slides. It would be, so it's the National Health Resource Center on Domestic Violence. You can access it just through the Futures website if you went there first, futureswithoutviolence.org, or it's in one of the last slides in the presentation, futureswithoutviolence.org/national-health-resource-center-on-domestic-violence. So it's long, but if you go to futureswithoutviolence.org and go to their tab that says Health, you can access all of their materials.
Okay, great. Thank you. And we will share that. That will be accessible through this webinar page. So if you didn't catch all of that, you'll certainly be able to access that after the webinar. So again, I just want to
for your time.
Thank you so much. I want to thank you for such a great presentation. Again, to our attendees, the PowerPoint slides will be posted on the website as a PDF. You'll be able to get access to that link there as well. We do have a certificate of completion that you can request. We'd like for you to complete the evaluation survey prior to requesting a certificate of completion. The evaluation survey is critical to the success of our project and allows us to continue to maintain our funding. And all of the links for the survey will be posted on the website as well. Thank you again for joining us today. We'd like to thank our partners, the BIG Initiative, NORC, and the National SBIRT ATTC. And finally, if you have any questions about SBIRT implementation, evaluation, training, or technical assistance, please feel free to follow up with any member of the SBIRT team here. We hope to see you all in the future and looking forward to inviting our participants back to the next webinar in our mini-series on IPV and SBIRT. Thank you.